A very good afternoon to everyone. So we'll start our instruction course. So our main highlight of the instruction course is to talk about demystifying Iols and the newer formulas which are in place right now. Our chief instructor is Dr. Krishna Prasad Kudlu. So there will be like 6 of us giving 6 different talks about what's happening around right now. So any doubts, any questions, we can take it up in the discussion at the end. So we'll start initially the talk by Dr. Vikram Jain, who will give us a talk about optimizing biometry. Dr. Vikram Jain is presently right now available, but his talk is recorded. So we'll go ahead with playing the presentation right now.
Okay.
Good evening. I'm Dr. Vikram Jain. I'll be talking about optimizing biometry. Biometry basically means measuring different components of the eye and deriving the intraocular lens power from it. The two measurements that we use for biometry is keratometry and measurement of axial length of the eye. Keratometry means measurement of the corneal curvature, the power of the cornea, which is determined by the corneal curvature. This should be done before any contact axial length measurement is done. For keratometry, you can either use a manual keratometer or an ARK, automated refraction and keratometer, or topography based keratometers. All give pretty good results. Manual keratometry has a learning curve. Once you mastered it, even that is accurate as the ARK. For axial length measurements, you have the optical and the ultrasound methods. Optical ultrasound methods are highly operator dependent. If the operator applanates the cornea, it can give rise to a lot of errors. A 1 millimeter applanation can give rise to a 2.5 diopter post-op refractive surprise. So make sure that there is zero applanation at the time of measurement. In ultrasound based axial length, measurement is from the corneal surface to the internal limiting membrane of the eye. For applanation, a few tips. Make sure that your machine is well calibrated. Every machine comes with a small glass cylinder. It's either fixed in your machine or it's supplied separately for calibration of the machine. Use correct velocity settings. For example, if your patient has a IOL in his eye and you're measuring it again for some purpose, make sure you're in pseudophakic mode or silicone oil mode in an eye filled with silicone oil. Look at the echoes which are displayed. I'll come to that later. Take multiple readings and use an average of the readings. So I was telling you to look at the echoes. You have four main echoes. One is from the probe cornea interface. The next two are from the lens, the anterior surface and the posterior surface. The next main one that we require is from the retina. Behind that, you can have another echo from the sclera, which we disregard. So these four echoes are what you have to look into. The amplitude has to be equal and there should not be too much noise on the baseline. If there is a lot of noise, that means that the gain settings are a little too high. You can decrease the gain so that the background resolution decreases, the noise decreases, and there's no compromise of the resolution. Gain is basically electronic amplification of the sound waves by the machine. Increased gain would be required when it's a dense cataract, and whenever the media is has better clarity, lower gain should be used. To overcome the problem of applanation, you have the immersion technique. It's a little difficult in view that you have to have an IV stand which is connected with some fluid which acts as a media in between the probe tip and the cornea. You can do it on your regular slit lamp chair, recline it and do it. It's a little messy though. Limitation of immersion is that cleaning this Praga shell is very, very difficult. It's got a groove inside it. It's never totally clean. You might transmit infections from one patient to another. Some special situations which can have inadequate patient fixation and measuring by ultrasound might become difficult. Patients with low vision, nystagmus or strabismus. With experience, you can get good measurements even with such patients. If not, like in nystagmus, you would rather do it after blocking the patient and do it in OT itself. In case of a posterior staphyloma, always be on suspicion in case of a myope, wherein the retinal spike, if you look at this one here, the retinal spike is not of the full amplitude. When you have a short spike in a myope, that means that you should suspect a staphyloma. That's because of this curvature, which is not exactly the 90 degrees. It's getting reflected elsewhere, and therefore the amplitude is little lesser. Keep a close watch for such low amplitude spikes in myopes. Whenever there's a patient with silicone oil, I already mentioned, use the silicone oil mode. Optical biometers use light, and the echo delay of reflected light from a diode laser is used in both the Dial Master and the Lens Star. They also have the keratometry inbuilt in them, so that you don't need a separate machine for keratometer. The formulas are inbuilt, and you directly get the readings of the given IOL, whichever IOL you want. One thing to remember is here the measurements are from the RP and not the internal limiting membrane. Therefore, the A constants used for ultrasound and the optical biometry are different. A constant for the given IOL. IOL Master 700 is based on swept source OCT technology. You also get a image of the eyeball, and hence you can double check that. The resolution in IOL Master 700 is 0.01, and it takes a very short duration, around half a second, to measure for one eye. It also has a lateral slit illumination to get the AC depth, as well as the posterior corneal curvature, which is required in the newer IOL formulae. Advantages of IOL Master 700 over other biometers, optical biometers, the Lens Star and the IOL Master 500, is that in fairly dense cataracts also there is good penetration, also in posterior subcapsular cataracts. Only in a total mature cataract, an IOL Master 700 would not give a reading. The only limitation is positioning patients in an upright position. If it is a bedridden patient, then it becomes difficult. To conclude, biometry is highly operator dependent. If the surgeon himself is doing it for every patient, even a good quality ultrasound would do. But in busy practices, you are getting it done by a technician. With optical biometer, you can be more confident that it is more accurate. If at all you are doing ultrasound, make sure that the appellation is very, very gentle. You're in the correct mode. And for higher modern lenses, trifocals and all, try to do an immersion ultrasound scan. In optical biometry, when doing it, make sure that the patient has got a good centration and it's not an off-axis measurement. Thank you. With that, I conclude. Thank you.
That is Dr. Vikram Jain for you. So I think we'll start with the second talk right now. So the second talk will be about monofocal IOLs, and I'll be talking about monofocal IOLs in a moment. So just 1 minute. So good afternoon, everyone. So I'll be talking about monofocal IOLs. So I have no financial interest to disclose. So I'll start my presentation by giving a tribute to Dr. Harold Ridley. So he was the first one to implant the monofocal IOLs in the 1950. Coming to the natural crystalline lens, so it has a characteristic of giving us accommodation, clear vision at all distances, even great contrast, no rotational asymmetry or minimal aberration. The natural crystalline lens doesn't have, cannot compensate for the corneal aberrations, but the newer IOLs have shown admirable ambition in overcoming this shortcoming. The IOL, mainly the monofocal IOLs, they have evolved from being only from made up of PMMA or silicon to now made up of acrylic hydrophobic or hydrophilic ones to the now present aspheric ones. Basically, an ideal monofocal should give you a clear optical quality, uncompromised vision for distance. It should be easy to implant, PCO protection, glistening free, lesser incision size for the implantation, and less inflammation after the implantation. Still, we can, we still ponder over the question of which is the best IOL model which is there in the market, whether we should go for hydrophilic or the hydrophobic ones, and how do we prevent rest of the problems like the PCO. I'll start by addressing the problem like the PCO. It's basically the source is the equatorial cells of the capsule. These basically migrate and they come in contact between the IOL and the PC. This is basically a multifactorial problem, which can be because of a surgical technique or the material or anything, but we cannot differentiate, which is the exact one single source which causes the PCO. Coming to the design, it basically depends upon the optic size, edge profiles, and the haptic materials. A square edge on the posterior IOL or the sharp edge on the haptics or a lesser angulation, this basically provides a barrier for the lens epithelial cells against moving into the coming into contact with the IOL. So basically, our final goal will be to minimize the decentration, dislocation, or decrease the aberrations from the IOL. Glistenings is nothing but the condensation of water within the IOL polymer matrix, which occur when the IOL is in the aqueous. Basically, all the IOL materials demonstrate glistening other than the hydrophilic ones. Here, your vision is not compromised, but your contrast sensitivity is reduced. Refractive index, talking about it, like the hydrophobic acrylics, they are associated with more pseudophakic dysphotopsia than any other material. Hydrophilic acrylic, they usually mimic like the biological tissue due to their high water content. So basically, that's why the hydrophilic IOLs reduce the glare and other aberrations compared to hydrophobic ones. Talking about ultraviolet light, anything less than 400 nanometer is toxic and it usually causes a retinal damage. So anything more than 400 to 440 gives you a better contrast and help especially in patients with ARMD and all that. It prevents against retinal phototoxicity. So most of the lenses right now come with a UV coating to help against all these problems. Coming to the main aspheric IOLs, the idea of aspheric IOL is to return the eye to that of the young optics. So basically, what happens is it gives you an extra excellent contrast and a high quality of vision. Keep in mind three things before you go implant an aspheric IOLs. You go for check the Q value in your aberrometer. Then again, like even you need to see a spherical aberration in the uh, Zernicke's polynomial in the 6 millimeter zone. So depending upon your Q value, if it comes negative, then you go with a positive aspherical one, or if your Q value comes positive, you go with the negative aspherical ones. So basically, it is designed to offset the positive spherical aberration of the average cornea, and this in turn gives you an improved contrast, particularly when the pupil diameter is large. Coming to MICS, basically, we all know the advantages of what the MICS gives us right now. Because your incision is smaller, there is hardly any astigmatism, your eye is more stable, there is quick rehabilitation and all this. But to get an advantage of all this, we need MICS compatible lenses. Otherwise, the surgery or the advantages which we want from MICS, it becomes really not fruitful. I'll just talk about the different IOL models which are available in the market right now. I'll start with iHands from Johnson & Johnson. This is basically labeled as an enhanced monofocal IOL. It basically, it slightly gives you an extended depth of focus. It's not falls into the category of EDOF. Basically, this creates a unique anterior surface which slightly improves your intermediate vision, but your distant vision is not compromised. And this IOL provide lower incidence of dysphotopsia. Coming to Clarion from Alcon, this is made up of a new hydrophobic biomaterial, and there is modified edges there. So your centration or rotational problem is not having a problem here. It has an asymmetric biconvex optics. So this actually helps in your easy visco removal, or even if a patient undergoes a silicone oil implantation later due to a retinal surgery, the silicone oil getting adhered to the lens chances is pretty less. Acryl IOLs from Biotech, it contains a uniquely covalent bond of natural chromophore, which protects for your UV against the UV rays. There is the optimally hydrated hydrophobic lenses, which when comes in contact with your aqueous, this doesn't give you much more glistening. It is manufactured using natural yellow hydrophobic material. So that's why your chromatic aberration is going to be less in this kind of an IOL. Rayner has come up with their own lenses, namely the Ray 1 EUMV, which has a center which will give you a positive spherical aberration, and in the blend region and the periphery gives you a negative one. So basically, this doesn't allow your imaging quality to be reduced, and it actually can be used as an MICS surgery with, again, it gives you an extended, slight extended range of vision like the iHands. Coming to Axial from Care Group, this is basically an hydrophobic lens, which is again aspheric optic profile with a 360-degree square edge. It has a refractive index of 1.5, which again decreases your glistening effect. Zeiss CT Lucia is a monofocal, fully preloaded hydrophobic acrylic. So this property is made of a lattice cut manufacturing technology, which gives you an edge sharpness. And basically, since it has a C loop, it is again having a Zeiss optical patented concept, which decreases your capsular and the IOL contact, which so basically PCO is the less. Coming to their more premium model, that is the CT Asfina 509. So this has made up of hydrophilic surface with a hydrophobic surface. So this has an again aberration neutral or aberration correcting version, for which depends on your surgeon choice. Basically, it's a 4 haptic lens. So this in terms of it's a very excellent IOL when we talk in terms of any rotational problems or centration, which is not seen here in this kind of a premium IOL. So what you're getting out of the Zeiss 509 is the best of both worlds, where it has an hydrophilic body, which is best for your uveal biocompatibility, easy to implant, and in MICS surgery with no glistening, with an hydrophobic surface, which gives you a PCO protection. So ease of implantation for any MICS is basically better to go with the hydrophilic lenses. Older hydrophobic lenses used to be harder and brittle, but now most of those issues are addressed now in the newer IOLs which are coming into the market. Preloaded lens comes with, again, yes, the no-touch sterility, it's quicker case turnover. Again, your lens handling damages reduce in the preloaded IOLs which are there right now in the market. So Rayner's is having a easy to use two-step system, which has a unique lock and roll technology. And again, it is an MICS compatible one. Alcon's injector is mainly, again, it has come up with their new speed control lever, which helps to see the lens you can release the lens in your own controlled manner. Zeiss Blue Mix's injecting systems comes with a different, again, MICS compatible one, where you inject your visco and the lens is taken out and easily, it can be loaded and injected. Basically, we see the future of coming, again, a lot of lens coming into the market of different shapes or materials, which is done. Again, we need to see more of this rollable IOLs or the light adjustable IOLs coming into the market. I conclude my talk by telling, an IOL is not a total package. Both its physical characteristics and a material are important to know how it's going to function. Basically, right now we are having like an hybrid materials holding promising and giving the best of qualities what anyone can get it right now. So we still need to wait it out, like which one IOL material we can have all the ideal properties and having the advantage and disadvantage. Thank you. I thank everyone for being patient, and I thank KOS for giving me this opportunity. Thank you, one and all. Dr. Krishna Prasad will be speaking next. Dr. KP will join in a while, so we'll start with Dr. Chinnappa. He'll be presenting here, so just 1 minute. I'll just load his presentation.
Can you hear me? This is Dr. Chinnappa here. Shashank, is my screen visible there?
Yes, sir. Yes, sir. It is visible.
Yeah. Yeah. Good evening, everybody. And I thank KOS and Dr. Elan Kumar in particular for actually giving me this opportunity to make a presentation today. The topic of my presentation in this instruction course is mainly about extended depth of focus IOLs. As we know, there is a myriad of IOL options available to the surgeon, and it is for us to decide what is best for our patients. So whatever said and done, the whole idea or the whole intention when we replace the cataractous lens with an artificial lens is to try and get a vision which is as close to natural as possible. But then it is not very easy to play God. So we try and say that we are trying to get as close to natural and never be able to reach the natural vision. So now coming to the other options that we already have, monofocal is the most widely used, mainly because the considerations of lifestyle and cost come into play when we make a decision for the patient. So about lifestyle, I will come in future, but as we know, the monofocal is the more cheaper option when it comes to the patient, and the multifocal, the trifocal, and the extended depth of focals or enhanced monovision is all more expensive. So yes, I mean, there are way lot of advantages in the monofocal as compared to a multifocal, as we all know that most of our monofocal patients do not have much complaints as compared to our multifocal patients, because it's a very simple technology. We are not really playing with the brain or asking the brain to do more than what it is usually accustomed to do. So, but then came the multifocal lens for people who wanted both distance and for near, especially where people wanted a spectacle independence. But then, yes, we were able to achieve this to a large extent, but it came at a cost, because of the light distribution. What happened is there was some light which was lost, and that reduced the contrast sensitivity, and near vision acuity, I mean, was moderately okay, but then the contrast sensitivity and the overall brightness and the color sensitivity was a bit lower than a monofocal lens. Then came the trifocal lens. Yes, the intention of having a trifocal lens was to address the problem of intermediate vision, because with changing lifestyle, there are a lot of people who would say that they don't usually pick up a printed matter ever in a day. It's either a digital screen or nothing, or they're looking at far distance. So for such people, intermediate vision became all the more important, and that's where trifocal did a great job, and it still does a great job. So coming to, I've already spoken about the advantages of multifocal and trifocals, but there is a downside. The downside, the number one downside of multifocals and trifocals is the glare that is associated with it. And sometimes some people, some patients do come back and say that the glare is unbearable. And for people who say that they have a very active nightlife, like driving or going out, socializing, partying, for such people, these glare can become unbearable and they cannot live with it. So that is when we thought that, this set of patients who are going to comprise a large proportion of our surgical patients for cataract in the future, they needed some kind of an option. And for that, for such patients, the only option or the best option that we have at the moment is the extended depth of focal lens. So if I have to go back and tell you, extended depth of focal is for people who say that, yes, we want spectacle independence, but then we definitely don't want the glare. So in extended depth of focus, there is a compromise between the monofocal and the multifocal. There is a better spectacle independence as compared to monofocal, with far lesser side effects as compared to the multifocal. So yes, so this is useful for patients who are sensitive to the visual side effects, but do want kind of a balance, like a spectacle independence and a visual side effect balance. So if this slide clearly explains that, if you see, it is not no visual side effects, it is less visual side effects. Have we been able to completely take care of glare and halos in 8 to 9? No. We have been able to largely reduce it, but not able to completely take care of it. So lesser visual side effects, number one. Have we been able to make the patients completely independent of glasses? No, because we are only promising the patient intermediate vision. But the best part is we are telling this to the patient in prior. So we are reducing the patient's expectations. So the patient knows that for reading, if they ever want to read printed matter, they would need glasses. So that's the beauty or ease for the surgeon when it comes to EDOF, and it is a little less expensive as compared to trifocal lenses. So we have much experience with the Zeiss 829, which is called AT Lara, and that comes with something called a smooth face technology, wherein the chances of glare and halos have been all the more lesser as compared to the other. I mean, I wouldn't, it wouldn't be ideal if I would say it, but then with personal experience, we have noted that, large number of patients say they don't have any kind of visual side effects. So this light bridge optical design is almost a continuous range of focus. Like I say, it is almost a continuous range of focus. In the multifocal, there is some amount of jump. There is a zone of vision where the patient can't see. That does happen in multifocal, but in this light bridge design, that doesn't happen. It is a continuous range of focus. But like I said, the addition is mainly for far intermediate and intermediate. What is intermediate? Anything beyond 70 to 110 centimeter is intermediate. Beyond 110 is called far intermediate. I mean, there's no clear definition of where the far intermediate ends and the distance begins. So that's about that. So like this is just a comparison between the multifocal, trifocal, and the EDOF. EDOF does have some kind of side effects, but it's way lesser than the others. And coming to spectacle independence, like I said, yeah, I mean, this probably is an exaggerated number. It's almost about 40% of people do say that I just don't need glasses, but then more than 50% say yes, they need glasses. So the defocus curve being more flatter as compared to other lenses, that shows that the binocular defocus curve being more flatter says that the kind of vision that they have has less amount of hassles. So again, I mean, when you're implanting a multifocal, you have to be extremely careful of people who have undergone probably corneal treatments in the past, and people who have high angle kappa and higher order aberrations. But then that kind of a choosy attitude need not be there when we are choosing an 8 to 9 or 80 Lara, because this is absolutely independent of decentration and tilt. Even if there is a mild amount of decentration, it can still take it. So this is just a summary. Like I already told you, it is a balance between lesser visual side effects and far better spectacle independence. This is just a video showing how the surgery is done. Like I said, a good round central, not too large rexes is mandatory in any kind of these premium IOLs. And implanting the lens and centering it is no different from any other premium IOL. So this is just the lens. Like I told you, it comes with the Blue Mix injector, which is a preloaded platform. Once it is clicked on to the injector, it goes in extremely smooth with the 1.8. Although we don't really do 1.8 regularly, it's 2.2. And once that is done, the surgery is nearly as the same as any other cataract surgery. So this is our experience. Like I said, almost 85% had 6/9 or better uncorrected monoocular, and 100% of them 6/9 binocularly. And N8, bilateral N8, because we chose to do a slight offset of about 0.5 myopia in the non-dominant eye, and that can actually add to the benefits of the EDOF IOL. In conclusion, more spectacle independence, lesser visual side effects. Thank you. Over to Dr. Shamant.
Excellent presentation, Dr. Chinappa. I think, Shamant, can you hear me?
Yes, sir.
Yeah, excellent presentation from Chinappa. I think any questions means we can take in the end. I think let me go to my presentation. I'm sharing my screen. I think, are you able to see my presentation, Shamant?
Yes, sir.
Yeah.
I think we can make it full.
It was really nice presentation from all of you. I think, sorry, I joined little late. So in continuation with Dr. Chinappa's presentation, I will be talking about my experience with the trifocals. Of course, Chinappa already told about the different type of IOLs available in the market. This is my financial disclosure. I'm consultant for Carl Zeiss India. As he already said that these are the greatest features of natural crystalline lens, which has got a good accommodation in all distance, in all lighting conditions, with a great contrast sensitivity, minimal aberration. These are the options for correcting presbyopia. I think already EDOF been clearly told by Dr. Chinappa how I've been doing a lot of corneal procedures, especially presbyon. I'm getting a good results, but make sure that patient doesn't have the cataract. Some of my friends been doing this something called laser procedure. So this is about the refractory IOLs. I think I'll not tell much about it because already Dr. Chinappa has been told about the diffractive IOL. But what exactly happened, the principle is whenever there is a plane waves are transferred into the spherical wave after the diffraction, there is a constructive interference due to the parallel phase relation results in a new wave. So grating density and refraction angle is very important. If a lens has got a higher the grating density, that means stronger is the angle deviation of light. If there is a more rings are placed on the lens surface, that means higher is the add power. So you can see in this picture, shorter the width is always higher the add power, wider the width, always lower the add power. Suppose if you see here, if it's +4 in the lens, that means it is around 3.2 at spectacle plane. If it is +3, that is around 2.25 at the spectacle plane. These are the few limitations with the multifocals. Of course, definitely there is a patience with the glare and halos. Very important about the intermediate vision, because most of the professionals now they mainly depend upon the intermediate vision, especially drivers, computer professionals. If you implant them a multifocal intraocular lens, I think they have to really change their lifestyle. This is where the trifocals in come into play. Of course, basically this design is of mix and match of both first generation bifocals and the second generation bifocals. So today I'll be talking about my experience with the trifocal 839 MP, mainly from the Zeiss platform. Basically, it has got a plus 3.33 near addition for a comfortable reading, and it has got an intermediate addition of plus 1.66. So it is a design is especially optimized for reduced visual potential and improved night vision. If you see any other lens in the market, the greatest feature of this lens is a smooth microphase optic design. Because of this, there is an ideal optical image quality and a reduced light scattering. If you see in the picture, almost 85% of the patient, the light transmitted rate is much higher compared to any other lens. So especially these lenses really do well when you implant in a younger patient. They'll be always spectacle independence because of this asymmetrical light distribution for distance, intermediate and near. And it is even optimized for night driving and reading in the low vision light. And the one more advantage, these lenses are 4 haptic. I can say it's a 4 haptic lenses. Some people call it as a plate haptic. It is something called a hybrid lenses, hydrophilic with a hydrophobic surface. Along with that, it has also got an anti-PCO barrier on the posterior surface of the lens. This is just comparison of this lens, especially how the lens in comparison with other bifocal intraocular lens and the trifocal of other design, how the lens behave, especially in 3 mm and the 4.5 mm pupil size. If you think about even intermediate vision also at 3 mm and 4.5 mm, these lenses are really work well because once again, because of the asymmetrical distribution of the light. See, if you compare, if the patient is seeing for distance, suddenly if they want to focus back to near, this how the lens definitely behaves compared to any other lens available in the market. So already Chinappa has told about this, the advantage of this blue mix injector. It is a preloaded injecting system, very good. So you need to take out from the cartridge case. Then initially the instruction you have to see in the templates given by the company, then go to the slot, just put it, press it, you'll hear a click sound. Now you remove the cap, then under the microscope you load, make sure the lens in the proper position. Then once it's in the proper position, you can lock like this. Then put some amount of viscoelastic behind the lens and also from the tip. So once if it's done, I think it is all set to go for injecting system. Then see, this is how I'm just showing you. See, here we have done the fake with almost a very small pupil. I think even after the good fake emulsification, you need not have to worry. These lenses go very easily, as Dr. Chinappa said, that through even 1.8, but this is a 2.8 incision. How well it is gone inside the bag. So this is our results of 132 eyes of 76 patients, mean age around 58. And the patients are come for a follow-up of 3 years and 2 months. This is how, like, you can see the uncorrected distance visual acuity with the best corrected distance visual acuity. You see, hardly you can say end of 3 years also how the lens is stable and hardly any spherical equivalent is remaining, thanks to once again Iols Master 700. This is about the uncorrected intermediate visual acuity, which is almost around N8 to N12. Even almost 96% of the patient doesn't require to wear the glasses for near vision. Compared to the even EDOF lens, the defocus curve is pretty good here. If you take the patient complaint, okay, how much of the patient really complained of glare and halos? Only it's bothering about around 5% of the patient, but 70% of the patient are really happy with the There is no glare and halo. Only 6% of the patient really required to wear the glass for a very fine print. These are our even results with the trifocal toric lenses. In the patients with 52 patient, 84 eyes, mean age of 67.13, 12.69. You can see here how compared to same like the trifocal lenses, how the lens behave pretty good. You can see spherical equivalent is not much remaining. See, if you see, once again, I do use the Callisto system. Once again, thanks to Carl Zeiss India. Because of this system, I think if your marking is dead dot on, 80% of the patient did not had any residual astigmat. You can just see these plate haptic lens really behave very well as far as the toric platform is concerned. Absolutely, there is no rotation of the implantation. In conclusion, trifocal intraocular lens implantation can perform by an cataract surgeon who is aware of the principles of refractive surgery and handles the precise intraocular lens calculation. AT-LISA TRI demonstrated excellent functional distance, vision at distance, intermediate and near in all our clinical evaluation. Almost all patients enjoyed spectacle independent after AT-LISA TRI implantation in this clinical evaluation. Thank you, Anandal. Thank you, Ilan, for the wonderful opportunity. And over to you, Shamant. Shamant?
Thank you, sir. So now we'll start with Dr. K.V. Satyamurthy's topic. So he'll be talking about post-refractive surgery do's and don'ts, a very important topic for us right now. Over to you, sir.
You have to share the screen, sir.
Yeah, and unmute.
Can you hear me now?
Yes, sir.
Yes, sir. Yes, sir.
Okay, thank you. Yeah. Thank you very much. At the outset, I would like to thank Dr. K.P. Kudlu and Ellen Kumaran for giving me this opportunity. Now I am going to discuss about post-op refractive surface, how to manage. There are various reasons. This is a common problem for all of us. And occasionally we come across, we have done a wonderful surgery and then expect the patient to appreciate our efforts. But to our surprise, patient will not be very happy with the outcome because he has got refractive error. Now let's see what are the reasons. Can you see my screen, Shaman?
Sir, yes, we can make it full screen, sir.
No, it is full screen only. Can you see this or not?
It's a half screen, sir.
It's half screen, is it?
Slides. Slides full, sir.
Yeah, now how is it?
It's the slides show. I think you have to press, sir.
No. No, for me here it is coming the full screen.
Okay, sir. Fine, sir. Let's continue, sir. No problem. We can read it.
No, 1 second. So now let's see what are the causes. Maybe the instrumental error. It may be because of the biometry, which has been already been discussed. Now it can be human error because in case if you are doing say contact A scan or immersion A scan, sometimes it can be sometimes there may be a wrongly labeled IOL, which very rarely occurs, but it does happen. So in any case, patient will have refractive error. It may be in the form of only spherical errors, or there can be astigmatism, or there can be higher order aberrations along with this, which reduces patient's vision. So now, what are the management options? In case if number is very small, better to counsel the patient and then explain him about the pros and cons of surgery. And then maybe in case patient has got monovision, say myopia in one eye, which you are contemplating correction, maybe you can talk about the monovision and then tell the patient. Usually most of the people, they settle down if it is a small number, and then give them glasses or contact lenses. In case if that doesn't work, then there are other options like IOL exchange, or we can put another lens. This is called the piggyback lens or supplementary IOL or add-on IOL, or one can do laser vision correction, or one can implant a phakic IOL.
So 1 second,
Yeah.
the slides are not moving, sir. It's still in the first.
Still in the first.
Yes, sir. Your main first slide, we are in that.
Okay. Shaman, shall we do one thing?
Yes, sir.
If someone else is ready, please tell them to start the thing. I'll just rectify this. Let's see. Okay.
Yeah, sir.
Yeah.
Shashank, can you play Dr. Sunil's video?
Yes, sure, sir.
Yeah. We'll start with Sunil sirs and then we'll come back to Satyamurthy sirs.
Okay.
I'll be talking to you regarding the secondary IOLs. Main indications for secondary IOL being the secondary aphakia, IOL related complications, or uveitis, glaucoma, emphysema syndrome, or patient dissatisfaction in some of the cases are the indications for secondary IOL. There is various techniques of secondary IOL available, which I will be discussing one by one in subsequent slides. It starts from antechamber IOL to iris claw IOLs to iris sutured IOL to transscleral fixation of the IOLs. ACIOL is one of the easier techniques to do. The haptics are quite flexible, but some of the cases where it is contraindicated, like eyes with got a large degree of peripheral antisynechia, those who have got glaucoma, shallow AC, insufficient iris tissue, and poor endothelial count, these IOLs are contraindicated. And these can also cause chronic inflammation and endothelial damage also. Consider patient age while implanting an ACIOL, select appropriate size IOLs, ensure that the haptics are positioned properly. Check for the capsular support if it's there or not before putting an ICOL. Put a pilocarpine to constrict the pupil, do a peripheral iridectomy, and the chamber should be very well maintained. Look at the orientation of the anterior chamber IOL. Either you can do a clear corneal incision or a scleral tunnel for the placement of this IOL. Typically, the orientation of this IOL is in the form of an anti-S or a reverse S-shaped incision one should look for, as shown in this picture. And once you have put that, you can dial the IOL in an anti-clockwise, unlike other IOLs, and place it in the support of the angle supported. You can place it and you can suture the clear corneal wound if it required. Sulcus placement, it is definitely indicated when there is enough capsular support or anti-capsular support. Support can be assessed by putting an iris hooks also, and you can release the synechia adhesions between the iris and the capsule. 3-piece IOLs are preferred in these cases. Sometimes can cause pigment distortion, optic capture, and peripheral iridectomy needs to be done in some of the cases. Another technique is a posterior iris claw IOL. Here the haptics of the IOL are enclaved onto the iris surface, posterior part of the iris surface. It's a faster technique, but the only thing is sometimes during enclavation, iris chafing can occur, and if you forcefully enclave, it can cause pupillary ovalization or distortion. Grasp the IOL. Once you have formed the AC, place the IOL in the anterior chamber, grasp it with an iris claw forceps, and enclave the IOL. Sometimes the late dislocation of the IOLs are also seen. This is I am showing the one part of the enclavation. The side port preferably should be made on the scleral side than on the clear corneal side, so it helps in the better manipulation of the better manipulation and less complications. Enclave the IOL. Once you enclave, you can see the dimpling on the surface of the iris. That gives a clue that the iris has been enclaved properly. And the similar maneuver can be repeated on the other side, and you will get a well-centered pupil with a well-centered IOL. This is a very easier technique, but needs to be done with a gentle maneuvers. The other haptic being enclaved here. Okay, that's it. Now the other technique is the iris sutured IOL, where you can use a Prolene suture through and through clear corneal and mid iris and come out of the cornea again, and same maneuver can be repeated on the other side. So once you pass these sutures, there are a part of the suture which is behind the IOL is pulled out and formed a loop. That loop is pulled out and put it across the haptic of the 3-piece IOL multiple times, so it forms a snugly the suture fix approximates to the haptic of a 3-piece IOL. Once you have done that, pass it under the iris, pull the sutures, then the suture ends can be cut and tied. So this is one of the techniques which can be done if there is a sufficient iris tissue, but it is contraindicated if there is an iris defect, iris atrophy, floppy iris, and other things. But this also causes inflammation in some of the eyes and pigment dispersion. The other thing is a transscleral fixation of IOLs. The many techniques have been described in the literature, starting from the sutures to glued IOLs to M&A techniques to flange techniques. Let me explain a couple of them. The sutured scleral fixated IOLs is an age-old technique where you use a 10-0 Prolene, or sometimes a Gore-Tex suture can be used. Either you do a 2-point or a 4-point fixation. 4-point fixation gives a better stability, but make sure that you bury the scleral knots, or the knot should be under cover of the scleral flap to prevent the suture exposure or erosion and chances of infection. Here the scleral flaps are being made, and the 10-0 Prolene is passed across after passing it through the 26-gauge needle. This maneuver has to be repeated twice. Once you have done that, you tend to have a sutures, then the sutures are pulled out and tied to the eyelets of the haptics on the clear fixated IOL. Then the IOL is positioned, try to put the left side of the IOL first and then the right side of the IOL, then gently pull the sutures, and the globe should be taut and well maintained, because hypotonous globe can cause decentration of the globe, and even the tightening procedure may cause some complications. So keep the volume of the eye either by maintaining within a past planar infusion, so that the suture tightening will be easier and centration also will be easier. Make sure there is no entangling of the sutures. Once you have placed that, pull both the sutures and tie the knot and bury the knot under the scleral flap. The next technique, which is translatory technique, which has been described, is the flange technique using a 50 prolene. Here we tend to use a 27 gauge needle and make a marks which is around 2.5 mm from the limbus on either side, and use a 27 gauge needle and thread the prolene suture into that. Once you thread the prolene suture into that, see, I'll show you the technique of this is how the prolene is threaded onto the 27 gauge needle. Once you have done that, then pass it through the 2.5 mm behind the limbus and get it into the pupillary area. Once you get it into the pupillary area, you need to pull that suture and tie it to the burn the tip of the prolene suture so that it forms a bulbous end and it causes a flange, and pull the prolene sutures on either side, and it can be placed easily behind the iris. And the one good thing is the prolene suture is very sturdy, so it is easier to pull the sutures, and chances of suture breakage and other things are less, unlike 10-0 prolene suture. Pull it. Okay. Once you have done that, pull both the sutures on either side. Place it in behind the iris. Okay, and then you can fixate the IOL like this. The other thing is a glued IOL and the glued IOL and the needle fixation of the IOL. Here the main thing here is a haptic externalization. In a glued IOL, haptic externalization is done with the help of a forceps. In a M&A technique or intrascleral haptic fixation, one tend to use the needles, or a 30 gauge needle or a 27 gauge needle to externalize the haptics. And after here the scleral flaps are made in the glued IOL, but there are no flaps in the intrascleral fixation as shown below. And once you have externalized the haptics on both the sides in a glued IOL, you tend to bury or push the remaining residual haptic into the groove which is being created on the sclera. So the chances of haptic exposure will be less. Here in an intrascleral fixation, you tend to burn the tip of the haptic so it becomes bulbous and it is buried into the scleral tract or in the scleral groove created by the needle tract. So sutureless scleral fixation, one need to be familiar with the vitrectomy technique that marks precisely the 180-degree axis, and choose the lenses which have got a sturdy haptic, but still there is a risk of bleed, breakage of the haptic slippage, and many things. And post-operatively, there is a risk of retinal detachment and other things. Sometimes the supplementary IOLs can be used, the secondary supplementary IOLs can be used like this. The phakic IOL being used for an eye refractive surprise, which is post-cataract surgery. Similarly, sulcoflex IOLs can be used. It's a toric sulcoflex, which is being used as a supplementary IOL or a secondary IOL, which is like any other hydrophilic IOL, which is loaded into the cartridge and injected into the sulcus. But the D criteria for sulcoflex IOL or the supplementary IOL is the primary IOL should be in the bag, and the sulcus should be very well maintained. You can just place the IOL in the sulcus and dial it into position so that the results are excellent with the sulcoflex IOL as long as the primary surgery has been done very well. So regarding the pediatric secondary IOL, the results are excellent, the IOL power calculation is an issue with the any pediatric IOLs, and it's very challenging scenario. And you tend to have a pigment dispersion and optic capture in the places of if it is placed in the sulcus. But in the bag, if there is a sufficient bag support, the placing in the bag is the best part of the secondary IOL implantation in pediatric patients. but the visual rehabilitation is one challenging issue with either primary or secondary surgery in a pediatric case patient. And earlier the secondary IOL, it is better in the pediatric case. So which technique to choose? Each technique has got its advantages and complications. Preferable to avoid AC IOLs. Consider the age and capsular support before putting a secondary IOL. Pediatric secondary IOL is a challenging scenario. Choose the surgical technique which best suits for you and which you learned it very properly, avoiding any complications. Thank you for your patient hearing. With this, I would like to conclude my talk.
Thank you, Sunil. I think all we have finished before time. Shamant, you are around?
Yes, sir.
Yeah, all we finished before.
We have Satyamurthy sir is pending. Satyamurthy sir is pending.
Sir is the sir.
Yeah,
We can
KP,
hear you, sir. We can hear you very
Can
well.
you hear me now? So now I'll share my screen. Yes.
Yes.
KP, can you see the screen?
Screen, no, it's written there has started. Yeah, we can see your screen, sir.
Yeah, now you can hear me also.
You can enlarge, sir. I think you can hear. You can continue, sir, presenting.
Okay, fine. Now just see, does it move?
Yes,
It's
sir.
moving,
It's moving, sir.
You can continue, sir.
Okay. See, that's what post-op refractive surprise. It's a common problem for all of us. It may be because of instrumental error like biometry or even any of the instruments for that matter, which is not being properly calibrated, or it can be human error, especially when we do contact biometry or immersion biometry, or there can be manufacturing error. Very rarely it occurs that IOL is wrongly labeled. This has happened to us also. So it can be in the form of spherical errors, or it can be in the form of astigmatism, or there can be combination of the two, or sometimes there may be higher order aberrations, which is reducing the vision. So we'll have to address these things. In case if the refractive surprise refractive error post-op is very small, then probably we can counsel the patient and explain him about the monovision and the things like that. If patient is convinced, usually most of the people, they will settle down. They don't want to undergo again surgery. So these people can be given either glasses or contact lenses. In case if the number is very high or patient is not happy at all, then probably we'll have to do one of these things. Either you exchange the lens or you add another lens, supplemental lens, which Dr. Sunil just now said, or you can do laser vision correction, or you can put a phakic IOL on that. So this is a case of IOL exchange where the patient, this was done about after 3 months prior to the surgery. Patient was not willing for any other compromise. So finally we decided to exchange the lens, and it was a hydrophilic lens. So first you will have to, under viscoelastic, pass iris depositor under the capsule. And since it was only 3 months, it was not very firmly adherent to the IOL surface. So IOL was finally brought out, and through the main entry, which was around 3.2 millimeters. Yeah, you can just take one haptic out, keep the rest of the haptic and the IOL in the bag, and then copious viscoelastic, you just cut the haptic. Now there are other instruments available to hold the IOL as such, but it is, in my opinion, not really required. All that you have to do is stabilize the lens and use a good long 1S. You will have to cut the surface. It's easier to cut the hydrophilic lens. You can also cut the hydrophobic lens, except maybe PMMA. So once you cut more than 3/4, then all we can do is you'll have to just rotate the thing and bring it out, as you see here. So once you remove the lens, now bag is intact. You inflate the bag with viscoelastic and open the bag. In case, just remove all the additions that are there, and you can implant the appropriate lens. So this is one way of doing IOL exchange. There are so many other ways. Now, what are the problems with IOL exchange? One thing is, again, we are depending on biometry, which can go wrong. So IOL power calculation can misfire, or there can be challenges related to the IOL explant. After all, it's a surgical procedure, so one has to be very careful. You may damage the poster capsule. There can be other things that can happen. And then, so one need to have a proper strategy for exchanging the lens and should use a proper instrumentation. And of course, endothelial protection is of paramount importance. Usually, in case if we don't take adequate precautions, we may end up with aneledema. So now, this is one aspect. Second thing is either you can put a lens over the pre-existing lens, that is called add-on lens. What I am showing here is a Sulcoflex lens from Rayner. I have no financial interest in this, but since I have experience only with this, I am just talking about it. So this has got haptics which are long, and they've got undulating surfaces, undulating margins, which prevents the rotation of the lens, and it is made of hydrophilic acrylic, and the angulation is around 10 degrees, so that the body, that is the optic, stays away from the iris. KP, am I audible?
Yes, sir. Yes, sir. You are audible, sir. Continue.
Yes, sir.
Okay, right. So now, the optic diameter is around 6.5 millimeters, so that here it comes both the spherical, aspheric, multifocals, toric IOLs. So depending upon the refractive surface that we have, we can either modify, we can you choose the lens. The overall diameter is from 12.5 to 14 mm. So based on the white to white measurements, either you can go for a smaller one or bigger one and place lens in the sulcus. The advantages are that it is highly predictable and it's reversible. That is the best part of it. You can just take out the lens and patient will go back to his original things. The indications are there can be post-op refractive surprise. That is the topic of discussion today. It may be in the form of spherical or astigmatism, or sometimes the pseudophakic presbyopia. Many patients, they want multifocality, so you can use a multifocal IOL instead of, and place it over the thing. The prerequisite is that the original lens should be within the bag, so sulcus should be free. And then you can also correct higher, especially spherical aberration. You can put an aspheric lens, and then you can correct the dysphotopsia also. So here is a case where a 34-year-old female presented with cataract, and finally the toricity was corrected, but patient had -3 diopters of spherical error. So now you can see the lens which is going in. The original previous lens is within the bag. So all we have to do is just tuck the haptics and make sure that the haptics go into the sulcus. It's very, very easy. The whole surgery may take about 5 minutes. In case if the anti-segment is small, maybe one can do a small iridotomy to prevent pupillary block. This particular patient, -4 lens was implanted, and finally patient had 6/9 unaided vision, and patient was happy. One can also use laser vision correction. One can do laser correction in the form of PRK or LASIK, and one has to wait for the wound to heal properly. And then one can also do pseudophakic presbyopia correction with the laser. Now, what are the advantages with that? I'll not go into details of these things. One thing is the results are accurate and highly predictable, and one can do customized treatment. In case if patient has got higher aberrations, we can do the remove that also. We can do presbyopia correction, and then it can be performed when the PC is not intact, especially following a capsulotomy or the previous PC rent. One can go ahead and do this. Only thing is the limitation is that we'll have to do with the low to moderate myopia or hyperopia, and then spherocylindrical errors can be corrected. One can do multifocality, and these things we have discussed. So minimum is 3 months of cataract surgery, where the wounds remain tight and well sealed, and then refractive stability is achieved. And the pre-LASIK evaluation is like earlier. Only thing is we are dealing with old people, so dryness is a common thing, and then laser vision correction per se adds dryness, and diabetes is another problem that we will have to keep in mind. So now here it's a patient, a 65 years old lady. She had a surprise of -2 diopters, and PRK was done, and best corrected visual acuity is 6/5, and she is fine even today. And this is a young patient, with the -7 and -2.5 in one eye and -2 in the other eye. So LASIK was done, and 6/18, it was a congenital cataract. So patient is having this unaided 6/18 vision and doing well. And here is a multifocal lens. The one eye was fine, other eye had -2 diopters of sphere. And finally, that -2 diopters was removed with the help of surface ablation. The patient is fine. One can also do limbal relaxing incisions using femtosecond laser, which is highly predictable and accurate. This is, I will not go into these details. A lot of studies have shown that patients who have undergone laser vision correction for post cataract surgery refractive surprise, they're much better than the Iols exchange. So this is a better option in case if that facility is available. Otherwise, one can any time put a ICL or IPCL or any phakic IOL, put it in the sulcus. But this is again an expensive option, which most of these cases patient will not be willing to pay for the second surgery. So finally, one has to find out the cause for IOL power surprise. I'm not going to say most of the times it is improper biometry, and then one will have to counsel the patient. In case if patient is not willing, or if the refractive surprise is more, one can exchange the lens or use the supplementary IOL or do the laser vision correction. Thank you very much for your patient listening. If there are any questions, I would like to answer. Thank you, Dr. KP, once again.
Yeah, thank you, KVS sir. Thank you so much for your wonderful presentation, as usual. So, just a couple of questions from my side. Do you have any experience with the Sulcoplex multifocal lenses in your case series?
Yes, I have done. For a patient who underwent surgery some 20-25 years back, this particular patient came from US only for this surgery, and he is fine. He's doing well. Multifocal Iols I have implanted in the sulcus.
Sir, my one more question.
Yeah.
That of course we do use. I still remember me and Dr. Chinnappa, who is also part of our instruction course. We did one of the patient for Sulcoplex. Patient had a lot of residual error remaining because of the biometric error. Patient had a very long eyeball. We had implanted -8 IOL power. Then later on, still there was a remaining of still more -10. Very long eyeball, but still we could able to put a Sulcoplex and we could able to get a good results. But what they say that even Sulcoplex toric lenses are available. That's what the company say.
Yes.
But see, we'll be putting the lens in the more in the sulcus.
Yes.
How about the stability of these toric Sulcoplex lenses?
That's what. See, the haptics, they have got undulating surface. They prevent the lens from rotating. So this is how you achieve rotation stability. But the only thing is your white to white measurement has to be accurate. So in case the sizing is proper, you can still use these lenses.
Okay, sir. And patients with you have done multifocal intraocular lens. Suppose if you have got a residual error, especially some patients, high old patients, actually during our primary pre-op assessment, normally patient will have a 0.5 cylinder. Normally you would have put a regular multifocal lens. As the age goes on, the patient may come back to us with a 1.5 cylinder. It's remaining in the correct. Patient, and we will not be like a patient will not be happy after 1 year of our multifocal. Have you tried any PRK to such patients?
No, I have not tried on any patient, but the PRK is definitely a good option in these cases.
Yes, sir.
Definitely. Yes.
Thank you, sir. It was pleasure seeing you also. Sir is in a good mood. Sir is inside the OT also. Always you are the source of inspiration for me, sir. Always. Once again, thank you so much. Thank you so much, Shamant, for that you started the session and your presentation was also good. Thank you, Dr. Chinnappa, Dr. Vikram Jain, Dr. Sunil Ganekal, who is also part of this presentation. I thank one and all for this. I think, hope to see you all. I think Chinnappa is also here along with Shaman. Nice to see you, Chinnappa. Satyamurthy sir and Shaman for a wonderful IC. I think, thank you one and all.
Thank you.
Thank you, sir.
Thank you.
Yeah. Thank you, everyone. Thank you, Lancer. Thank you, Coscon. Thank you.